Good morning, everyone. This presentation will be on specific phobias. Phobia is defined as a marked fear or anxiety about a specific object or situation, even to the point of panic when exposed to the feared object. Examples of these objects or situation are flying, heights, animals, receiving an injection, or seeing blood. Phobia is the most common mental disorder with a lifetime prevalence of 10%. This is the most common mental disorder among women, the second most common among men, second only to substance use. Specific phobias of the natural environment type and natural uh, or rather blood injection injury usually starts at around 5 to 9 years old. Situational type phobias like flying, heights, social phobia develops in the mid-20s. This graph shows the prevalence of specific phobias. The black bars represent the lifetime prevalence of specific phobias among the population, and the blue bars are the percentage among the respondents with specific phobias. Animal type phobias is the most common, followed by heights, closed spaces, flying, and injection-related phobias. Behavioral factors were implicated for the development of phobias. This was first described by John B. Watson in the 1920s, where he recounted his experiences with little Albert, an infant who is afraid of rats and rabbits. His hypothesis relies heavily on the learning theory to explain the development uh, of the fear responses. However, in classical conditioning, the stimulus gradually loses its potency to arouse a response if not reinforced periodically, which is not seen in phobias. Operant conditioning theory thus provides an explanation for this phenomenon, wherein the organism learns that certain actions enable it to avoid the anxiety-provoking stimulus. This avoidance these avoidance patterns remain stable for long periods as a result of the reinforcement they receive from their capacity to diminish anxiety. In phobias, such avoidance behavior becomes fixed as a stable symptom because of its effectiveness in protecting the person from the phobic anxiety. Freud's formulation of phobic neurosis is still the analytic explanation of specific and social phobias. He hypothesized that the major function of anxiety is to signal the ego that a forbidden unconscious drive is pushing for conscious expression and to alert the ego to strengthen and marshal its defenses against the threatening instinctual force. He viewed the phobia, or what he termed anxiety hysteria, are results of conflicts centered on an unresolved childhood Oedipal situation. He described this in detail with little Hans, the boy who feared horses. Genetic factors were also noted to contribute to specific phobias. Some studies show that being a first-degree relative of an individual with specific phobia puts one at a greater risk for specific phobias. Particular phobia transmitted, however, are different, but usually of the same type. The existence of a disorder in the family does not automatically imply genetic transmission. However, shared learning experiences and other environmental factors could explain why phobias run in the family. Diagnosis of specific phobias based on the DSM-5 criteria is for criterion A, there is marked fear or anxiety about a specific object or situation. Criterion B, the phobic object or situation almost always provokes immediate fear or anxiety. Criterion C, the phobic object or situation is actively avoided or endured with intense fear or anxiety. Criterion D, the fear or anxiety is out of proportion to the actual danger posed by the specific object or situation and to the socio-cultural context. Criterion E is that the fear, anxiety, or avoidance is persistent, typically lasting for 6 months or more. Uh, and the fear, anxiety, or avoidance causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. For criterion C, the disturbance is not better explained by the symptoms of another mental disorder, including fear, anxiety, and avoidance of situations associated with panic-like symptoms or other incapacitating symptoms. This is further specified as per type. So we specify if it is animal type, natural environment, situational or others, or blood injection injury. For blood injection type, it is further subdivided to fear of blood, injection and transfusion, fear of medical care, or fear of injury. Phobias have traditionally been classified according to specific fear by means of Greek or Latin prefixes. Names for common phobias are as follows. So, for example, here, fear of heights is acrophobia, fear of open places is agoraphobia, fear of cats is ailurophobia, for fear of water, it's hydrophobia, closed spaces, claustrophobia, for fear of dogs, cynophobia, and fear of animals, zoophobia. Of course, the list goes on and on. There's a specific phobia for each type of object or situation. For the clinical features, specific phobias are characterized by the arousal of severe anxiety when patients are exposed to specific situations or objects, or when patients even anticipate exposure to the situation or object. Exposure to the phobic stimulus almost invariably results in a panic attack. The patients try to avoid the phobic stimulus to or for example, one will drive from Davao to Manila just to avoid flying. For the differential diagnosis, this includes non-psychiatric medical conditions such as substances, for example, like hallucinogens, CNS tumors, and cerebrovascular diseases. Also, schizophrenia can also be a differential diagnosis for specific phobias because phobic symptoms could be part of their psychosis. However, in comparison to phobias, patients with phobia have insight into the irrationality of their fears and lack the bizarre quality and other psychotic symptoms that accompany schizophrenia. Other anxiety disorders could also be a differential diagnosis. Patients with specific phobia tend to experience anxiety immediately when presented with the phobic stimulus. Um, Compared with other anxiety disorders, the anxiety or panic in phobia is limited to the identified situation. Hypochondriasis could also be one differential diagnosis, but in hypochondriasis, it is the fear of having the disease, in contrast to, for example, illness type phobia, wherein it is the fear of contracting the disease. For the course and prognosis, specific phobias have bimodal age of onset as was discussed earlier. So, for example, for natural environment and injection type, they usually occur at around 5 to 9 years old, and situational type phobias usually occur during the mid-20s. Due to the limited perspective epidemiological studies, little is known with regards to the phobia's natural course. But most specific phobias that begin in childhood and persist into adulthood will continue to persist for many years. The primary goals of treatment for specific phobias is to decrease the fear and phobic avoidance to a level that no longer causes significant distress or functional impairment. In some cases, uh, another goal is to include strategies to improve specific skill deficits. Pharmacologic treatment for phobias is generally thought to be ineffective, but it is not uncommon for patients to be prescribed with benzodiazepines. This could be, or some studies suggest that benzos could be helpful in the short term, but may lead to greater relapse in the long term. SSRIs, particularly paroxetine, when compared with placebo, um, showed superiority over it in reducing anxiety and fear levels. Behavior therapy is the most studied and most effective treatment for phobias. Its key aspects are that the patient's commitment to treatment, there is a clear identified problems and objectives, and that there is available alternative strategies for coping with the feelings. Systematic desensitization is behavioral therapy that is widely used for phobias. Here, the patient is exposed serially to a predetermined list of anxiety-provoking stimuli graded in a hierarchy from the least to the most frightening. The aim is to remove the fear response and substitute it with a relaxation response. There are three general steps to systematic desensitization. First, the patient is taught a deep muscle relaxation technique and breathing exercises. This step is important because of reciprocal inhibition. Reciprocal inhibition is where conflicting responses, it is believed that conflicting responses cannot occur at once. For example, anxiety cannot occur with relaxation. So the patient is taught relaxation techniques to replace the anxiety and fear responses to a stimulus. Second is that the patient creates a fear hierarchy starting at stimuli that create the least anxiety or fear and building up in the stages to the most fear-provoking images. For example, a patient who has fear of spiders, so the thought of a spider could be the least anxiety-provoking. So he could rank that as 1 or 10, or he or she could um, provide a score for the fear or anxiety for that, and he could build up on the stages, and the most provoking would be, for example, a spider crawling up his or her arm. So on the third step, the patient works their way up the fear hierarchy, starting at the least unpleasant stimuli and practicing their relaxation technique as they go. So the patient um, goes step by step in his or her hierarchy, and he or she would only go to the next hierarchy when fear is uh, or there is no fear response um, to that hierarchical um, stimulus. Example. If the fear is too much, then the patient could go back a step to the previous hierarchy before going up again. Another psychotherapeutic psychother Another psychotherapeutic way is the insight-oriented psychotherapy, wherein it enables patients to understand the origin of the phobia, the phenomenon of secondary gain, and the role of resistance, and enables them to seek healthy ways of dealing with anxiety-provoking stimuli. Another way is the computer-generated or the virtual therapy. This is computer-generated situation simulations of phobic disorders that have been developed. The patients are exposed to or interact with the phobic objects or situation on the computer screen. Recent advances would be the use of virtual reality modems such as what is seen in the picture. Other therapeutic modalities include hypnosis. This is used to enhance the therapist's suggestion that the phobic object is not dangerous, and self-hypnosis can be taught to the patient as a method of relaxation when confronted with the phobic object. Supportive and family therapy could also be useful in helping the patients actively confront the phobic object during treatment. Eliciting the help of the family could also help the patient in terms of support, and that the family could better understand the nature of the patient's problems. That's all. Thank you.